Good morning, everyone. We welcome you to day 3 of DRS Cody. And this session is definitely of particular interest to me. And we have a legendary panel, if I may say so. And it has been curated by none other than Dr. Usha Sriram herself. And we all know that she's one of the pioneering, she's one of the experts in the country who's done pioneering work in this field and continues to guide us and inspire all of us to develop that focus and work in the direction of diabetes and women. So, without much ado, may I welcome ma'am to just set the context and invite our panelists.
Good morning, everyone, and thank you, Purvi, for very, very kind words. Thank you very much. And I'm so excited that Purvi and Manoj, while organizing this program, have dedicated a session to this really important topic, which is looking at diabetes through the gender lens, because for long we've always thought diabetes is diabetes, one size fits all approach. And as we know, and as evidence has accrued, that diabetes is a very different animal when it comes to women. The adverse outcomes are more and more severe, and I'll discuss some of the actual numbers as we go along. But it's really important to look at it through the gender lens, not just to look at of course, there are biologic differences, but also the lived experiences of girls and women with diabetes, how the health system treats women with diabetes, and how women themselves look at look at any chronic disease for that matter, particularly something like diabetes. And so we'll try and put all this together. And more importantly, since we have such an amazing group of women who are going to be discussing this, the experts who are here, international experts like Professor Juliana Chan and Professor Asma Deep, and we have fantastic person from the Mumbai Municipal Board Corporation. And of course, Professor Neeta Deshpande, who not only is an expert in women's health, also her focus on bariatric health, I think, brings a special dimension to this discussion. So without further ado, again, let me invite all the panelists. Purvi, you want to invite them? Sure.
Professor Juliana Chan, please. Ma'am is a senior endocrinologist and one of the best epidemiologists in the world today. And with her body of work, I think we are all set to get some questions on, our gender disparities really coming out in clinical trials. Welcome, ma'am. We also have with us Professor Asma Deep. She's a senior pediatrician with a lot of focus on women's health and also type 1 and technology use. She's multifaceted, and again, I think we'll get a lot of insights into what we want to bring to the fore today. Dr. Neeta Deshpande, a leading obesity management expert, a bariatric physician from Belgaum, and everybody knows her here and outside, even for diabetes remission work. And may I welcome Dr. Neeta Deshpande. Dr. Daksha Shah, I think this was a much needed a track that we wanted to discuss, and we couldn't think of anyone better than Dr. Daksha Shah in Mumbai in particular. She's the executive health officer in the municipal Mumbai Municipal Corporation scheme, but she does some outstanding work in the field of NCDs, and she's been leading. I mean, it's surprising that such great work is happening in our corporation hospitals itself, but it's all being led by her, and we invite her to the panel as well. I'm going to take a step further, and this session has been very well curated by Dr. Shriram ma'am, but I'm going to request her to actually join the panel and not moderate it.
Sure, thanks. Go ahead.
Please take seat, yes. Have heard about the Beti Padhao Andolan? Almost everyone, right? Beti Padhao and Aage Badho. That we all know that. But how many of us are really aware of any awareness programs or any public health drives in our nation today by the government focusing on NCDs, particularly in women? I am very, very happy to see that at least our social media handles from the Ministry of Health and Family Welfare is now taking some extra efforts in sort of posting things in obesity, in NCDs, and their general awareness messages. And that's great because PM Modi also talked about the Fit India movement recently, a few months ago, and it's getting some impetus. That momentum is coming up. But at the same time, how many of us are really aware of what is going on and what is exactly, where are the gaps? Why are we not focusing on this huge burden of NCDs in women? And because that's going to take us a long way in actually preventing the next generation from suffering from it. So, that's the entire focus of this discussion, and we are hoping that we are actually able to come up with something in writing as well and publish it so that we can get more actionable items from that. So, Professor Chan, I'm following very actively, but I can see majority of the studies are focusing on the cardiovascular health and differences in men versus women. But do you really believe, as someone who's a global authority in this, are there enough intersectional studies considering not just gender but also class, ethnicity, and geography in diabetes research?
I think I agree there is a huge data gap in this area. As you already pointed out, that there are huge differences between men and women. Women, 50% of the world population, and biologically, but also there's culturally, also socioeconomically, behavior, all very different. And I think diabetes in women, it really represents a opportunity, where we can prevent this diabetes begetting diabetes. That they can influence the transgenerational diabetes. So I think there is really a gap of knowledge. I think we need to have some dedicated research documenting really the life course of a woman with or at risk of diabetes and their subsequent generations in order to make a difference. I think these data collection are very important to drive actions.
Fantastic. Thank you for, consolidating all our belief that there is a data gap that exists, and we probably have to attempt to bridge that very quickly. And it's not going to happen just with registries and stuff, but we really need to have large scale studies with different parts of the country also involved. And I think that's pan Asia. So that's the point well taken. And I think you alluded to a very good point that, diabetes or women, it's a great opportunity, and we should look at that window of opportunity. And that brings me to my next question to Dr. Deshpande. uh, Gestational diabetes, a great opportunity, completely missed actually, except the last few years that we're talking about it and bringing it in focus. So obviously the numbers with every IDF atlas, we know they are just exploding. The prevalence has increased. But as a physician with special interest in bariatric medicine, how do you feel that the challenge of maternal obesity can be tackled at an individual, community, and then at the policy level?
Well, you said it well that gestational diabetes is now exploding, and we know that obesity is one of the major drivers of getting gestational diabetes, major risk factors of getting gestational diabetes. However, although we have been talking about it amongst ourselves, in amongst the HCPs, how much of this has actually percolated down into the community is the question. We don't see many people coming for preconception obesity treatment, which makes life much easier in terms of gestational diabetes reduction, obesity reduction in the offspring. So, none of that is happening. So, I feel that more than anything else, at the individual and at the community level, a lot of awareness needs to be created for preconception counseling, for checking for obesity, treating obesity before even thinking of conception. It's not easy to do because not many people are aware that obesity can be the major driver for gestational diabetes. So a lot of work needs to be done, I feel, at the community level, rather than just it has to go hand in hand, or it has to run parallel with the awareness that we are creating among the HCPs. So a lot of work needs to be done in that. Nobody is coming to us for preconception other than if the gynecologist feels that this lady needs to lose weight, or if it's a case of PCOS, then okay, they come for preconception obesity treatment. But otherwise, it's not happening unless it's for cosmetic reasons.
I think India has done great on the screening front for gestational diabetes, as far as that universal screening goes. But any thoughts on how can we make a policy change in this matter?
As far as a policy change is concerned, I think people talk about blood glucose as being the fifth vital sign or the fourth vital sign. I think, at least for starters, body mass index should be. How many of our GPs or how many of our primary care physicians really bother to measure the BMI and tell the patient at what grade of obesity or otherwise the patient is at? It doesn't happen. So, unless our general physicians at that level are told that please tell your patient that you need to lose weight, a simple sentence, like it's like smoking. So, everyone knows that they should not smoke, but that one line from the physician is so important to reiterate every time. And in the same way, if the body mass index is considered as a vital sign, just like pulse rate and the other things, then I think we can go a long way in creating that. So that's not exactly a policy change, that's a change in practice. But as far as policy is concerned, there are n number of things that can be done. Packaging labels, making that compulsory, keeping calorie count in hotels, in every small little hotel. So there are a lot of things, and a policy change can happen at the level of the school. I think that is very important, on what is kept in the cafeteria, the teaching that goes on to the students in schools about what they should eat and what they should not. So, in that sense, a policy change can come at the level of the school, it can come at the level of the supermarket, and sugar tax maybe. So, a lot of things can happen at that level.
Thank you for bringing up that built environment that maybe we need to aggressively target that and bring about changes there itself. But you alluded to preconception care, and I just cannot think of anyone else but Dr. Usha Sriram to ask the next question. So, ma'am, why is preconception care your pet peeve, and again, at the individual level, how soon should we start talking about it? And at the policy level, what can we do? Some high level thoughts at least.
Thank you, Purvi. First shining the spotlight on this very important issue, because just as a segue from what Neeta just said, prevention of gestational diabetes can only happen if we start things before the pregnancy, because repeatedly we have seen anything that we start after the pregnancy has started really doesn't provide much, doesn't have much of an impact. So everything has to start from before the beginning, as they say. And unfortunately, across the globe, preconception care, there is somehow the adoption of preconception care has not been good, even in countries where there is a established program and people think about. So majority of pregnancies in low and middle income countries are unplanned. Even the ones that are planned, when we say they are planned, they are only intended pregnancies, but they're not like planned in the way we are thinking about it, not metabolically or otherwise planned. So if you look at it that way, most of pregnancies are unplanned. So when you have unplanned pregnancies, everything from unsafe abortions go up, pre-existing conditions. There was a recent audit from the UK which showed that women with diabetes, even with established condition like diabetes, there is very little preconception care, even when the services are available. So people with pre-existing conditions do not, get the necessary care. The third one is the health of women of reproductive age, 15 to 49, whether you look at the NFHS 4 and 5, or you look at independent studies, we see a lot of multi-morbidity, not just single morbidity, but multi-morbidities in these women. So the health of women of reproductive age of today has changed a lot. Pre-diabetes, obesity, overweight, thyroid, vitamin D, mental health issues, and other risky behaviors like smoking, drinking, medication, so many things like that. So we have all of these as well. And then, of course, going in things like polycystic ovary syndrome, other conditions. And as practitioners, whether it's OBGYNs or physicians or GPs, we're not getting into the looking at women's life cycle. When we see a patient in our office, we're only seeing them as a person with diabetes or as a person with this, but not as a woman of reproductive age. Or just ask that one key question: what is their reproductive plan? So all of these have to be factored in. It's actually not that difficult. As we heard in the previous talk, it's not a cakewalk, but it can be.
So I think that sensitizing is extremely important, because once we develop that gender lens, I think we, at least start with the key questions and then start intervening accordingly. We have Dr. Asmadeep, and till I'm completing my first round of questions, audience, gear up for your questions, because we are going to, have you ask them yourselves. So, Dr. Deep, adolescence is a very, very precious development phase where they are neither completely in charge and not completely unaware. Obesity in adolescence is rising globally, and at least in India, it's a huge challenge now. And I think the pandemic really worsened the scenario completely. And in fact, we have been seeing so much of adolescent obesity around, and people coming to us for help, and that's actually a positive change, that they actually want to get treated. What is your experience, and how exactly can we tackle this age group? We would love your expert comments on this.
Thank you very much indeed, Perry, for this. And I thank you specifically for including me as a pediatrician amongst the expert panel. Very good question. Juliana started by saying there is a gap in the literature about studies and diversity. And I cannot agree more. In fact, I would like to widen that gap when we talk about adolescents and pediatrics. You are all aware of how difficult it is to run research in pediatrics and how difficult to recruit pediatric patients in research. So my adult colleagues, if you have a gap in your literature and studies, I have even a wider gap when we talk pediatrics. And this is really interesting and puzzling me. We've heard yesterday our politician talking in this very podium saying that a country like India is a young population. The same applies to the Gulf. Yet, we have one pediatrician in a panel of 5, and we have much less work and research and clinical trial. So many of your questions, Bervi, in adolescent, will unfortunately remain unanswered. But to answer your question about obesity, and I like such panels to be a little bit more provocative, we need to pause and revise the definition of obesity, because if you rely in adolescent that obesity is BMI centile, then we might be leading ourselves in errors. If you look at India in particular, then prediabetes, PCOS, and others are in fact more common in malnourished girls. So are we taking the wrong definitions to come up with wrong conclusions? There are multiple studies in India which shows that girls with malnourishment, those who have a little bit of higher waist circumference, are in fact carrying more risk of obesity comorbidities like prediabetes. I'll save some of my comments on PCOS if you have questions about that. But if people are talking longevity, and that's the case nowadays in United Arab Emirates, so they say we need to make elderly people live better. You can't do that unless you start from pediatrics. In fact, like you said, start earlier. Look at the fetus, look at the newborn, school children, and then you can guarantee better geriatrics. So I can talk forever, but I'll leave the chance for my co-panelists.
Thank you so much for those very cogent comments. And I think they're all very well taken and gives us a lot of food for thought for further discussion. Let me rope in our public health expert from Mumbai Municipal Corporation, Dr. Daksha Shah. Closely working within the corporation, and you probably are more exposed than all of us to that strata. Do you see the burden of NCDs in as high as in the private sector? And what are some of the challenges you see at the clinic, BMC clinics, in women with diabetes in particular?
So thank you, Purvi, and greetings to all the co-panelists. See, as far as the burden of diabetes or NCD is concerned, I don't think so there is a difference between public and private sector. So let me clear out that very clearly. We should see the city as a whole, the Mumbai city or maybe a district or the state. And what is the burden of NCD over there? So do we have the sufficient data? So I would first say that we have done WHO STEP survey in 2021 and we published in 2023. And we have found that the diabetes prevalence is around 18% in the age group 18 to 69 years. And in that itself, we have seen that amongst the women, we have 21%, and amongst the men, it was 16%. So there we found that 5% higher rates of diabetes in the women. Similarly, for all the parameters which we measured in WHO STEP survey, we found that women, diabetes, pre-diabetes, everything is higher. The cardiovascular risk factors, over 10 years is more than 20%, and amongst women again it is more, that is 8.8% compared to men 7.7% something. And as far as treatment is concerned, amongst the treatment seekers, we found that the woman is less taking treatment, 5% less than the men. And as far as diabetes control is concerned, around 42% control we have found amongst those who are taking treatment, who are diagnosed diabetes, and in that amongst the men we found 50%, while amongst the women we found 35%. So on an average it was 42%. So again, the diabetes control was less amongst the women. So we all know, I think Dr. Neeta also described, Usha also described about various barriers which is there. So the same barriers we see it in even the BMC clinics. There are social barriers, economic and cultural barriers. Like women don't come out. They don't seek care early. And of course, even among the lower strata, I would say that the women are really burdened with so many other responsibilities. They are also the breadwinners in so many families, and they will put their health the last priority. So family, children, relatives, and all that, and then they are earning. So this all multiple pressurizes them not to come to the clinic. So what we have designed is we have ASHA workers and PHVs who go door to door. So we have started this door to door services where every Wednesday, like we have fixed one day where our ASHA workers will go in the houses and they will screen them for NCDs. We have CBAC scoring about the high risk, risk factors, and then they will promote this opportunistic screening of the women as well as the men, of course. But most of the time we don't get them because they are at work, and we measure the blood pressures and we promote them and we push them to come to our clinics to do their diabetes screening. So this is one proactive measures, as you were saying, that they are not much done on the public front. Yes, there are a lot of things which we are doing. The second thing I think Neeta was mentioning, Madam was mentioning, and you also mentioned, about the adolescents. So we now have a RKSK Karyakram, that is Rashtriya Kishore Swasthya Karyakram, which is now very much part of the government initiative. It's a comprehensive public health initiative which covers the age group between 10 to 19. And it has key 6 initiatives where the nutrition counseling, mental health, substance abuse, sexual violence, and of course the NCD is a part of that. And we have started the adolescents health friendly health clinics. So these are the initiatives which is just kind of starting, or it is in a process of starting. So we are also kind of planning establishing some adolescents health clinic this year in BMC area. Around 33 is our target, and we are kind of taking baby steps. I would say that there is a beginning somewhere, and the difficulties and the barriers are there. The system barriers are always there, but we are trying to overcome by improving the access. Like if you have every 15 to 20,000 population, we have health and wellness center. As you know that the government have a mandate to now start a health and wellness center for every 20,000 population. So that to improve the access. So we have started such Apna Davakhanas in all over Mumbai. Plus we have yoga centers. Now what we have found is today itself also we have 130 yoga sessions going on in the morning. And these are very near to the communities. And what we have found is that the woman uses this yoga centers more because, the houses are so small in the slum areas and they want to utilize these services. So I'm very glad that we could now do this yoga centers and this concept of health and wellness center bringing near to the community. So such initiatives are there, but yes, there are still barriers, and we are trying to kind of connect with the community through our health centers, through our staff, and we are sensitizing and we are trying to develop our TOTs, like, some of the ambassadors, we are asking the CHVs and ASHAs to be the part of this initiatives. So I hope, some of the initiatives I've described and it's happening in the field.
I have goosebumps as you speak. This is fantastic. Very, very heartening to know you've actually cleared the air around what the corporation is really doing in the health sector, and particularly in the NCD space. And I think we need more leaders like you to actually even talk about it and make everybody else aware about what is going on. I think the picture is very similar to what's happening to the type 1 diabetes care in our country. We do not know enough of your initiatives, and that's why there's no partnering, there's no collaboration, there's no scalability of that to the private sector as well, because everybody seems to be working in pockets.
Just adding it to your thing, partnerships. We do have, partnership for healthy cities, Bloomberg initiative, who is partnering with us. We are also roping in multiple national, international NGOs to take this forward. Like, you cannot do everything the government cannot do. So we need to have the partnerships. CBOs and NGOs have been roped in. Some of the NGOs like Sneha and so many other NGOs who are working with us. And, in the space of adolescence clinics as well as others, we have roped in the nutritionists. Like, we had partnership with Indian Dietetic Association, and we had roped in the dietitians who go every 15 days to our clinics. And especially they have the sessions with the women. So within the communities, those Mahila Bachat Gat and those Mahila Mandals and all that. So we are having a community sessions also. Then there is this nutrition month, Poshan Abhiyan, you might be aware of it. And
Yes.
individual targets are given to our primary health centers. And there's close monitoring. We have an NCD wing now, and we have been doing a lot of campaigns. I brought one campaign if you would like to play the clip. We just launched in the month of February for the awareness.
Thank you. Thank you for that. Let me rope in Dr. Juliana for the next question. What kind of gender responsive policies? We know that, again, there is good work happening in, say, N of 1 as compared to all the multiple thousand districts or lakh districts that we have. But what is your suggestion? What about the gender responsive policies that the governments and professional associations like the RSSDI or other bodies, what can we do for both research as well as new initiatives?
I think we have heard some very, exciting initiatives from India. I think they can really serve as an example for the rest of the world. Because, I forgot to mention, that we have this multi-centered Joint Asia Diabetes Evaluation Program register, where we have recruited more than 120,000 patients from 11 countries from Asia, and really reinforce some of the observations that the female patients were actually having worse risk factor control, particularly in lipids. And very interestingly, while the men were more likely to smoke, right, the women were actually less physically active. And I think that's really very important, that how we can create opportunity for these women to really do some exercise. And yoga is, of course, one of the really proven strategy to improve physical health and probably also improve glycemic control. The other thing is the waist circumference is also very interesting. Although women had lower BMI, but they actually have larger waist for the sex definition. And we know that the central obesity might be related with emotional health. And on that basis, we also know that women are also more prone to develop depression and distress. And this will also be very responsive to peer support. So having this kind of community-based program, right, where you can address physical inactivity at the same time providing peer support, I think this is very, very interesting. Now, of course, those are patients. This is really where they can actually start learning more about, women's health, right, their impact, the impact of their health on the second generation, on their generation. I think a lot of women don't really know that during that 9 months, right, they can have a impact on the future, development of the child. And there's a lot of studies like HARPO have already shown how, intrauterine exposure, right, to hyperglycemia can have a long-term impact on child obesity and also hyperglycemia. And the important point is, I think it's just all about literacy. I think women, once they realize that they have very, very strong motivation, to improve, themselves and also to improve the patient's health. And what we observed, right, in these different countries, we also found a lot of diversity. And education level is very, very important. Women with higher education level, they really do tend to have better health than men with higher education level. So, so this is really societal. So I think we must elevate the educational standards of women, right? And I think with that, they will help the husband, they will help the children, they will help their parents. But I think with a lot of community support. I think medical policy is important. Universal screening for gestational diabetes. It has to be, has to be put in place, because that is one opportunity where we can identify high-risk individuals, right? And then these people should be followed up, systematically followed up. And that is the opportunity to also evaluate the children. But what I really wish to emphasize is this data should be documented and to evaluate the impact and the program, because those data would drive policy change, because there are many, many competitive needs, right? And I think policymakers really want to hear this data, and we as practitioners would also want to see the impact of these practices and policies as well.
Fantastic. I think it's fantastic. I mean, I'm so happy that we're doing this panel because it's not now N of one, it's at least N of six who are speaking the same language and bringing out, important points. And we must come up with an action point from this particular panel discussion. Any questions from the audience? Okay, so I'm going to move on. Yes, please.
Yeah, hi, fantastic discussion. Just a small query. So nowadays, young women are more prone to PCOS, and most of the young women have a fear for taking treatment. Rather, they are very much comfortable to go to lifestyle modification. So, just wanted to know that is diabetes preventable, or is it getting delayed while they are on the PCOS treatment? Or what is that timeline they can end up in diabetes in the future if they are on treatment or not on treatment?
While all of them can, give you fantastic answers on that, I'll request Dr. Asma to start.
You might regret choosing me. You might regret choosing me because I have lots to say about the terminology of PCOS. Perhaps by the end of the year, you will stop hearing the terminology. There is a lot of work that's happening at the moment to correct the PCOS. We can talk forever about it, but that might be a side issue. PCOS is based on clinical criteria of menstrual irregularities and hyperandrogenism. That has nothing to do with cysts in the ovary, so this is just a side issue. Now, your other point is critical about people with PCOS and their relationship with prediabetes and diabetes. And I'd like to go back to the story of the definition of obesity and take young girls in India who are not obese by definition, but they have the metabolic prerequisite of having metabolic abnormalities. So we should move towards the modern medicine of definitions. People with obesity not necessarily are more predisposed to prediabetes and PCOS. It depends on what you mean and what your definition with obesity is. Are you basing that on just BMI? Or are you measuring the waist circumference and taking note of the genetic predisposition of prediabetes? So lots of complex things, and the way to treat PCOS is variable. Again, you have lean PCOS, you have girls who are defined as obese with PCOS. So are you going to start OCPs? Are you just going to start metformin, or would you rely on lifestyle modifications? Lots and lots of, I think this needs a panel in itself. So I'll stop there, Purvi.
Thank you. I took the point on peer support. I'm going to expand on that because I think we don't talk enough about peer support in the chronic ailments, particularly type 2 diabetes or obesity, and particularly women. I would like to bring that forward also because education will be the backbone of that peer support initiative also. But I would love to hear from our experts, Dr. Deshpande and Dr. Shida. Can start.
On peer support?
And education.
I think that's absolutely critical. And even just to continue this PCOS discussion, if I may. So the woman with or girl with PCOS and their family are primarily concerned about the menstrual irregularities and the acne and hair growth and hair fall. But I keep telling them that's you are primarily concerned about that. But I am more concerned about the 4 to 7 times higher risk of diabetes or the metabolic, the liver disease, and other issues that are cardiovascular disease. Those issues are, top on my list, and that's very important for us to. So as we talk to our patients with PCOS and their families, it's really critical to constantly keep bringing up the metabolic health of these girls because they're at higher risk for GDM, they're higher risk for type 2 diabetes, higher risk for cardiovascular disease, mental health, liver disease, all of those things. So that education coming from us is really important. But coming to your question, I'm a very big believer that what we need now is a campaign, big campaign on the on diabetes in girls and women, which will include all of these aspects. And this can be, come down from the government, or it can be public-private partnership, or even a private initiative, or RSSDI, or anyone can take that up. Something like the Go Red in the US that has completely changed the trajectory of heart disease in women. Before the Go Red was started, heart disease was going up like this in women in the US. As soon as they launched this, just an education program, not only it's come down so much, so that it has actually shown tangible results. So education at every level, from school level, community level, workplace wellness. This year's IDF theme is that workplace wellness. Everywhere, if we keep introducing the concept of how women can be both aware and what can they do to stay healthy and metabolically healthy, I think it will benefit a lot. And of course, all the professional societies can take this up in a big way.
Well taken, ma'am. Dr. Neeta, so with respect to adolescent obesity, I think that's really one of the areas of my interest because I think that's the turning point in the trajectory, in the life course, because, there's a lot of autonomy that gets self-taken at that point. So what is the best strategy you feel that we make them aware and make them make tangible changes which will result in better outcomes?
Yeah. Like I mentioned before, if you look at adolescents, right, I would say from the 8th grade onwards, you would want to call them adolescents, maybe. So from that until the junior college and the first degree college. So a lot, they are actually, because I have been doing a lot of these programs where I address the students and they come up with a lot of questions. So what I feel is that more such lectures and programs, and then talking to the authorities in the school or college for initiating or bringing about this awareness program, this you can have workshops for them where they understand where they are headed metabolically. Everyone talks about other things, and of course they're worried about the cosmetic issue, but once you talk to them about the metabolic implications of what they do now or do not do now in terms of lifestyle and activity, they're not going to understand. They have a rough idea that obesity is not good, diabetes is not good, but they don't know how they themselves can actually prevent it, what steps they can take, 1, 2, 3, 4, and they're simple ones. Screen time, for example. Give them alternatives of what they can actually do to make life easy, to make life pleasurable other than the screen. So this kind of a comprehensive program at the level of the school, not much time is given. They are not given even two. That's what we found out in the schools, that the syllabus is so big, there's so much to be covered, that if they have 1 hour slot every day for playground that is taken up by teachers who are rushing to finish the syllabus. So they end up with just 2 such periods in the entire week. So it is taken away from them as if those are times that you can just draw upon to do other things. So it becomes an option rather than a compulsion. So there are various things you can do at that level.
But to begin with,
Yeah.
I cannot agree more with you, because I think, and a lot of smaller studies, because we don't have a countrywide registry or countrywide initiative that any association has taken to study this. But there's
Actually, if I may interrupt you, 10 years ago, we did a survey on 3,000 children. So we took 1,000 children from government schools, 1,000 children from partially aided schools, and 1,000 children from completely private schools. And we studied their screen time, how many times a week they ate outside, what their BMI was, and all of that. And now we are planning after 10 years to go to those same schools and do the same survey again and look at the difference, because the screen time has increased, I'm pretty sure, because there was no Netflix even 10 years ago that much. So all of that we're planning to do in the same schools and see what we come up with. And maybe that could drive a little bit of policy at least the local level in our community.
And I think sleep, another important issue with that adolescent age group is sleep, and the sleep hours. So I think that's a very important point, but we don't talk enough to them where they can make tangible changes. Yes, Doctor.
I think the sleep is really, a lot of data now coming out. The pattern of sleep, right, is really associated with adverse cardiometabolic risk profiles and poor outcome. And it's very much related to screen time. Yeah, and I think, this is almost like a war, because we're living in a very interesting time. There's a lot of messages. And so it's really up to medical professionals, people who have the knowledge to really, balance, right, these kind of news, right? There's a lot of fake news, right? A lot of, sort of unrealistic expectations, right? Quick fix and myths. And so I think this is important, as Nita was saying, that it needs to occur at all levels, community, clinic level, school level. And starting with, it is a family-based business, really. I think a woman, gestational diabetes or polycystic ovarian syndrome, or even a young onset diabetic person, is already an opportunity for you to actually start identifying high-risk individuals with this family. And so that you can concurrently, implement prevention and also care strategies. Now, I think it's a challenging time, but there's also, the opportunity to change the trajectory for both generations and beyond. Yeah.
Fantastic.
Just
Yes,
add
Dr.
one
Nisha.
thing in the school. You know about the Eat Right India campaign, right? So I think all the schools in the city of Mumbai as well as outside, they have this curriculum. Plus, there is a scorecard for every school that if they implement this physical activities, healthy initiatives, and all, they get certain points. Second thing is the critical thinking. You have to invoke among the students the gimmicks of the marketing.
Absolutely.
Reading the labels and how this food marketing has been done. I think they are very smart. The students, if you give them this analogy and this comparison, I'm sure that they are smarter than us and they will realize it early, the better. So I think this critical thinking component, and make them the ambassadors or make them the champions, and then they will then have a peer educator programs amongst them and just propagate those campaigns, and kind of a movement that should be started in the schools more than the schools. I would say colleges, because school is a control environment, while the moment they step into the colleges, they are like free. So there is the catch where we have to catch them. And I feel that we have done a couple of films and campaigns, but we need to do more. Let them be creative and create for themselves. So I think empowering the students, especially the adolescents, and taking over their lives is more important.
One simple slogan that can, or a simple activity that can be done is for the adolescents and children is, do not eat anything that comes out of a packet. Simple message. Don't eat anything that comes out of a packet. That automatically goes to whole foods and fruits and vegetables. So don't eat out of a packet.
Fantastic. This is actually my dream panel, and I'm so elated, and I'm actually really happy, and it has been satisfying talking to all of you. I hope it has been the same for the audience, but you will see a paper from this coming out soon with all the thoughts enumerated. Thank you very much for this fantastic discussion. We could have taken the entire day, like Dr. Usha Sriram ma'am would have loved, and we should have that probably at some point. But thank you again, Dr. Chan, Dr. Deep, Dr. Neeta, Usha ma'am, and Dr. Daksha. Fantastic points brought out. Thank you again.